Hi, my name is Erica, and I'm be presenting on reduction of somatosensory evoked potentials using focused ultrasound median nerve stimulation. Focused ultrasound applied to the peripheral nerves in vivo can induce both sensory and motor responses. Studies from our group have shown that this FUS targeted to the median nerve can reduce nociception in healthy human subjects, and that this reduction is correlated to the amount of median nerve displacement. These studies have implemented ratings from subjects to evaluate pain reduction, but subjects often struggle to standardize their ratings across multiple trials. In contrast, somatosensory evoked potentials, or SSEPs, from electrical stimulation can be used to quantify neural sensory signaling in an objective manner. An initial study from our group found SSEP decreases for median nerve sonication, but these were evaluated with only 4 electrodes and trials were not randomized, introducing uncertainty when evaluating results. Ultimately, there's a clinical need for median nerve neuromodulation that can reduce somatosensation, as it could be used to treat chronic pain and weakness associated with conditions such as carpal tunnel syndrome. Our objectives here is to use EEG to objectively measure the ability of displacement-guided FUS peripheral median nerve sonication to modulate SSEPs in healthy human subjects. We also sought to improve upon our early studies by implementing a randomized procedure and an additional off-target control to ensure any observed modulation can be attributed to median nerve FUS. Overall, our hypothesis is that this FUS median nerve sonication can modulate SSEPs arising from electrical stimulation, and that the observed effects will be dependent on the amount of nerve displacement. In this study, electrical pulses on the median nerve induced a repeatable thumb twitch at a rate of 1 Hz. FUS was applied to the nerve upstream of this electrical stimulation, and displacement imaging ensured correct targeting of the median nerve. Subjects were sonicated with a 1.1 MHz transducer, and a 5 millisecond FUS pulse occurred at the onset of each electrical pulse and was repeated at the same 1 Hz rate. SSEPs were recorded with EEG throughout the experiment. 7 healthy subjects were recruited for the study, and each was sonicated at either 1.6 or 2.5 megapascals. Within each pressure group, some subjects experienced on-target sonication applied to the median nerve, whereas a single subject experienced sonication applied off-target from the median nerve as an additional control. In this study, on-target sonication was characterized as FUS focused onto the median nerve. Displacement was first confirmed with B mode and then with displacement imaging to ensure the FUS was targeted directly to the nerve. Off-target sonication was when the FUS transducer was placed 4 centimeters away from the nerve. This distance was chosen as it was the amount the transducer needed to be moved such that the nerve could not be seen at all in the B mode image or in the displacement. We did not expect to see SSEP reductions in the off-target condition. This condition was implemented as a control to ensure that any modulation observed was a direct result of FUS applied to the nerve itself. Initially in these experiments, a non-randomized procedure was implemented, where 2 separate acquisitions occurred, one containing all 500 sham pulses and the other containing all 500 FUS pulses. To better compare the sham and FUS conditions, though, a randomized procedure was later developed that used a single acquisition where the FUS and sham sonications were randomized throughout. In both procedures, cavitation and displacement were acquired during each FUS pulse and then post-processed. Multiple post-processing steps were used for the recorded EEG signals. To analyze somatosensation, we looked at traces at the CP4 electrode. The benefit of using electrical stimulation to evaluate sensory signaling is that very specific peaks are expected in the somatosensory region. In particular, we will focus on the early N20 and P27 peaks, since they are associated with the arrival of information to the somatosensory area and its production to other brain regions. First, we'll take a look at the 1.6 megapascal sonication. All patients here underwent the non-randomized procedure. Here, the averaged SSEP trace at the CP4 electrode shows an overall reduction in the FUS condition compared to the sham. To quantify reductions, we calculated the peak-to-peak amplitudes of the N20 to P27 peaks from the median nerve electrical stimulation. On a group level, an 8.2% amplitude reduction occurred at these peaks. Next, we can take a look at a video of the scalp topography from the P15 to N60 deflections. The white line on each scalp map tracks the size of the area of activation at each time point. This area of activation is quantified as the region that contains signal within a -3 dB range of the maximum potential in the somatosensory region between the two conditions. Across time, there is a consistent activation reduction in the FUS condition compared to the sham condition, with a 0.7 ratio between the two. At the P27 deflection specifically, we see a 74% through reduction in the area of activation in the somatosensory region between the sham and the FUS conditions. And finally, on a subject level, we see a consistent reduction in the overall area of activation and also the N20 to P27 amplitude. Next, we can compare the on-target condition to the off-target. Unlike the on-target, we do not get a reduction in the FUS curve at the CP4 electrode, or a decrease in the N20 to P27 peak-to-peak amplitude. Instead, there's actually an increase in this amplitude. When we take a look at the scalp topography, we see a consistent increase in the area of activation with FUS, with a ratio between the two of 1.7. Finally, at the P27 deflection, there is an overall increase in the area of activation in the FUS condition compared to the sham. Now we can look at the 2.5 megapascal FUS results. Here, one patient underwent the randomized procedure, whereas one underwent the non-randomized. Similarly to the 1.6 megapascals on-target group, there is an attenuation of the FUS curve at the CP4 electrode. Specifically, on a group level, the amplitude is reduced by 11.4% at the N20 to P27 peak, and this is greater than the 8.3% average reduction seen in the lower pressure group. In the scalp topography across time, there is a consistent activation size reduction in the FUS condition compared to the sham, with a 0.62 ratio between the two. Zooming into the P27 deflection, there is an 86.3% reduction in the area of activation between the sham and FUS conditions, and this is also greater than that occurred at the 1.6 megapascal reduction. Finally, on a subject level, we see a consistent reduction in the overall area of activation and also the N20 to P27 amplitude. Lastly, we can compare the on-target 2.5 megapascals condition to the off-target condition. Unlike the on-target condition, we don't get the same overall CP4 curve reduction with the FUS. An amplitude reduction still occurs between the N20 and P27 peaks, but is smaller than with the on-target sonication. As with the 1.6 megapascals off-target sonication, across time, there is a small activation size increase in the FUS condition compared to the sham, with a 1.4 ratio. Finally, at the P27 deflection, there was also a small increase of 30.5% in the area of activation in the FUS condition compared to the sham. This control subject conducted with the randomized procedure has the value of acquiring the sham and the FUS pulses in one procedure instead of two separate sonications. There's much less variation between the two since they take place under the exact same conditions. This randomized procedure makes us more confident that observed modulation is actually due to the FUS. To better understand the mechanisms behind this modulation and differences between the two pressure groups, we can look at displacement and cavitation. Here you can see the average cumulative displacement per pulse within the two on-target conditions. On average, there's a peak cumulative displacement of 4.16 micrometers at the lower pressure and 7.11 micrometers at the higher pressure. To the left, we can see representative videos from both pressures showing the inner frame displacement across one 5 millisecond pulse. A greater inner frame displacement occurs at the median nerve at 2.5 megapascals compared to 1.6 megapascals. In contrast, we can see from the spectrograms that neither experiences inertial cavitation. Instead, we get harmonics of the 1.1 megahertz FUS, likely rising from nonlinear propagation in the tissue instead of real stable cavitation. PCI of the two conditions also show no focusing of the beam, indicating no real cavitation. In conclusion, on-target sonication decreases somatosensation, specifically with a greater SSEP attenuation occurring at a pressure of 2.5 megapascals compared to 1.6. In contrast, off-target sonication slightly increased the SSEPs, indicating sonication must occur on the nerve to attenuate somatosensation. Greater displacement was found with the higher sonication pressure, and this was associated with the amount of SSEP attenuation. Cavitation did not occur at either pressure and therefore is unlikely to be the driving mechanism. And finally, a randomized pulse sequence successfully reduced variation in the off-target condition, indicating that randomization provides a more reliable comparison between FUS and sham conditions. For future work, we'd like to demonstrate the feasibility of the system to reduce pain and somatosation in CTS patients. I'd like to thank my collaborators and my funding sources, and thank you for your attention.